Alright, so I'm going to talk about acid-base balance through a little diagram. So acid-base balance is the balance between acids and bases. So when we have more acid, we are acidic. And when we're thinking about what acids are, it's going to be related to excess hydrogen ions or CO2. When we're talking about base, that refers to bicarb or HCO3. We're going to be measuring our acid-base balances through ABGs, so just drawing things from our arterial blood gases. So we'll be getting a little sample of blood from the arteries, and that can help indicate our pH and bicarb and the amount of CO2. So the balance is really when we're thinking about that 0 to 14 scale. When you are from 1 to that 7.35, you are more acidic. So when you have a lower pH, you're more acidic. Whereas with anything above that 7.45 to 14, you're going to be more alkaline. So our normal range is 7.35 to 7.45. But then again, anything less than 7.35, you're more acidic. And then anything above 7.45, you're going to be more alkalotic. If you're trying to think of, perfect compensation when you talk about your ABGs on if things are partially or completed or completely compensated, then thinking about if it's within that normal range, that would be okay. So have that little picture, acidosis versus alkalosis. Then we'll move forward to talking about the buffers and our regulators of acid-base balance. So we have a respiratory system and our renal system. So when we're thinking respiratory, we're really talking about it being a rapid response. Lungs act quickly, and then our kidneys act slowly, but it's more efficient. Again, with our respiratory system, we're going to be thinking about acid, so CO2. And then with our renal response, we're going to be thinking about bicarb. Again, acid-base balance is measured by ABGs, so I have the normal values here. You guys probably worked on ABG interpretation problems, so you can always be looking at those as well. So I'm talking really fast and can't write as fast, but we talked about the regulators. It'll all be written out, but just some examples of our acid-base imbalances. So when we have diabetic ketoacidosis patients, it's going to be a metabolic problem. So with our starvation states, and when we convert from using glucose and carbohydrates for energy, when that doesn't work in those severe starvation states, our body is going to use fats as energy. And when we break down fats are going to be broken down and they create fatty acids. So then you can expect our patient to be more acidic because they have the accumulation of fatty acids building up. So then our respiratory system is going to work fast. It's going to kick in really fast because it's our rapid response mechanism. So we're going to be hyperventilating and blowing off excess acid since we're in an acidotic state. And then that's going to help bring us back to normal by offsetting all that acid. Another example would be Heroin Harry, who passes out from drug overdose. In this instance, we have a respiratory issue. So he's not breathing, or he's breathing really low. So in that case, CO2, which is an acid, will be accumulating, and that's going to be a respiratory acidotic state. In this instance, since our lungs aren't going to be working, kidneys are going to be our hero. So they're going to work to restore our acid-base balance by kicking base back into the bloodstream, so bicarb, and that will help normalize our acid-base balance. And finally, we have Diarrhea Dan, who loses base out the back, aka diarrhea. So we're losing base, so that leaves more acid, and then our lungs are again going to be kicking in. So since we're more acidic, we're going to be speeding up respirations to blow off the acid and bring our acid-base balance back to normal. You guys received that little diagram on your alkalosis and acidosis. So alkalosis, that K for kicking up the pH, and then in acidosis, sliding the pH down. So just little mnemonics on how to memorize, but it should be pretty simple. So then I'm launching into a section on causes. So respiratory acidosis is caused by not breathing enough. So you're hypoventilating. So then you have your acid being held onto and you are in an acidotic state. So this can be in instances of drug overdose, respiratory depression, any lung impairment. So if you have chest trauma that affects lungs, they're not going to be able to breathe and expand as well. So then we have that issue. If you have an issue with your brain, like a head injury, you can have damage to a respiratory center. So again, thinking about hypoventilation, you have more CO2 or acid being built up. With metabolic acidosis, causes are going to be you're losing base. So when we talked about diarrhea Dan losing base from his butt, since you're losing all that base, you're going to be having more acid. We kind of talked about DKA too. So when you're producing ketones or breaking down fatty acids from using fat for energy as opposed to our glucose, then you have that buildup of fatty acids. So again, acid, acid, acid. And it's going to be a metabolic cause because it's not relating to breathing. Things like severe starvation modes are pretty similar concept. So you're going into that metabolic acidosis state from the breakdown of fats. Another thing is overdose of aspirin. So aspirin is also known as acetylsalicylic acid. So if you have too much acid, then you're going to be in an acidotic state. And then instances of sepsis, you can have a buildup of lactic acid. And again, more acid, not a respiratory issue, so it's going to be a metabolic acidotic state. With respiratory alkalosis, we have issues with breathing off or blowing off too much CO2, so hyperventilation. When you have fevers, you're going to be breathing faster, so again, breathing off more CO2. And then in early stages of pulmonary emboli, when you have issues with your lungs, you're going to be breathing off more and then losing acid, so then you're in a more alkalotic state. With metabolic alkalosis, this is caused by high acid loss. So in instances where you're vomiting, we talked about how vomit tastes acidic because it's generally stomach issues. We start vomiting and you have that bile, very acidic state. In our GI system, or our stomach is very acidic. And then NG suction. So again, it's in our gastric area. We're losing a lot of acidic gastric contents. So with a loss of acid, you're going to be more alkaline or alkalotic. And with high antacid intake, so these are acid reducers. So when you have a lot of antacids being taken, you're going to be more alkalotic.